Healthcareonomics, changing healthcare by changing the way you think about healthcare. Hi, everybody. Welcome to Healthcareonomics. I'm your host, Dr. Kevin Wacasey, and today is episode 2 of Healthcareonomics for Physicians. We're being brought to you across several platforms, including YouTube, iTunes, SoundCloud, and now our latest flagship radio partner with Mike Church's wonderful CrusadeChannel.com. You can find the links below, where you can find Healthcareonomics published every Monday now on the Crusade Channel. Please give that a look-see. Today I have with me as my special guest Dr. Shane Purcell from South Carolina. Dr. Purcell is a DPC, or a direct primary care physician, who practices without the confines of third-party payers or health insurance. Dr. Purcell graduated from medical school in 1999, finished his residency in family medicine in 2002, and has been practicing medicine ever since then. A few years ago, he decided to do the right thing, and I'm going to let him tell his story right now. Thanks for being on the show, Shane.
Hey, thank you, Kevin, for being a part of the show. Basically, when I got out of training in 2002, your debts are piling up. It's time to get things started, pay the bills back. So I signed up for a local primary care practice that was looking to hire a new physician, and did that for about 2 years, and realized pretty quick that fee-for-service was just not going to be a way for me to go with the paperwork, the pressure. They wanted me to see more and more patients to make my payroll every month.
Right.
In fact, at the end of my 2-year contract, they wanted to cut my salary dramatically because I wasn't seeing enough patients.
Wow.
So
So this is the good old corporate practice of medicine, as I like to say it. Was it an independent physician group you were working for, or was it a company?
It was an independent physician group. There was like 3 physicians in there.
Okay.
And so it didn't take long to figure out, this is not good for me. It's not good for patients. So I ended up leaving that practice and going and doing urgent care and trying to find my way.
Right.
And as I did that, in 2005, I started a cash-only clinic in my community, which is the only cash-only clinic that's ever been attempted here in our community. There's about 200,000 people in our community. And so
now, where is that again? Tell us where that is.
I'm located in Anderson, South Carolina, which is basically the northwest corner of South Carolina, near Clemson University.
Okay.
And so we're right in the middle between Atlanta, Georgia, and Charlotte, North Carolina, right on I-85, right in the middle.
Okay. So would you say that this is a rural area?
Mostly rural.
Okay.
Mostly. Greenville is one of the larger cities in South Carolina. Greenville, South Carolina, probably has about 500,000 people.
Right.
So our community is a lot smaller, for sure.
Yeah.
So as we started that cash-only clinic, I built up more and more patients. Over a few years, I had about 800 cash-paying patients.
Wow.
And so what happened is the economy tanked in 2009, 2010, and this was before really anybody was doing direct primary care.
Right.
And there wasn't an easy mechanism to do that monthly payment.
Right.
And so what happened was people didn't want to pay. They just didn't want to come in and pay, even though my fees were like $45 a visit. Nobody wanted to pay. And so I went in did more urgent care type work until the mind-blowing development of direct primary care with the monthly fees where you can directly draft it. As that developed, I was able, the light bulb went off again and said, hey, now's the time to get back into that cash mode with that primary care.
That's a little fascinating there. So you started way back in 2005. See, I'm an emergency physician by training, but in 2003 I got sick of doing emergency medicine, which is, let's face it, mostly primary care anyway. So I decided to open my own practice here in the Dallas-Fort Worth area. I had several problems that I did, several marketing mishaps, et cetera, that I did, but it didn't take off. That was in 2003, and that was at a time when deductibles, if you'll recall, health insurance deductibles were only about $200 on average across the country. Now, of course, they're in the thousands of dollars. But back then, it didn't really make sense for people to pay out of pocket for their health care if they had health insurance. So you're saying that in 2005, you actually made this work and it kept going for years. But you're saying that at that time, you weren't doing the monthly payment model. You were doing just a fee for service. If they came in and got sick for something, they would come in and okay, gotcha. Right. And then it was the crash of 2008, 2009 that really tanked that idea for you.
Right. Because what happened was people obviously they only wanted medicine. Just call my medicine in for me instead of coming in and paying for your visits.
Right. And so, we would love to do that, but we can't make a living just doing that. I understand. Yeah.
Correct. Yep. And so we progressed from there. In 2000, had built up an urgent care following and had my own urgent care that I started in 2008. And then my current partner, Dr. Amy Cianciola, contacted me about helping her set up a direct primary care. She wanted to do a cash clinic as well. She wanted to get out of the system she had been in for 17 years, working for a local hospital system. She didn't know how to do it. She'd never had her own business. And so we spent a lot of time together, and we opened, she actually opened in August of 2015, and then I trailed her 3 months. But we joined together to open our first direct primary care practice in Anderson County in 2016.
Wow. So she was working within corporate medicine then. She was working for the hospital and all that entails. That's a whole other series of podcasts, folks, as to how that can go awry. So you did an urgent care from 2009 onwards through 2015. Were you taking cash and health insurance there, or how did
initially we were doing both.
Yeah.
We were taking some insurances, and then as Obamacare sort of had its full effect, and those deductibles went through the roof, it became really untenable trying to hold on to those insurances because people were paying out of pocket anyway. And it was cheaper for them to just pay us $90 for a visit than to try to track down money. So we got out of the insurance game in 2015 fully, and we were doing cash walk-in visits and physicals and things. And it made it easier to transition to DPC, which is to opt out of all insurances, get out of Medicare.
Right.
I'd been opted out of Medicare since the early 2000s, so I didn't participate with Medicare for a long time.
Oh, good for you. Yeah, I've been opted out ever since I left the emergency room back in 2016. I said, nope, no more, never again. Mm-hmm. Wow. So this is kind of you were finding your place, but it sounds like you met with a lot of success. A lot of patients saw the value in just paying you. I wish more patients would do that because it really makes so much sense. So in 2015, you and Amy formed, y'all joined forces and you formed what you have now. Tell us the name of your clinic there in South Carolina.
Okay. It's Direct Access MD.
Okay. And how did y'all form that? How did y'all work that out? Did y'all look around at other physicians, what was going on? Did you have any kind of sources to learn from, or was it all just, well, for me, it was kind of hard scrabble, but then I started learning pretty quickly when I looked around. So how did y'all accomplish that?
So I had been doing a lot of research online, looking at videos. There's a lot of resources online through the AAPS and some of the conferences that post up online. You meet some of the big players in direct primary care, like Josh Umber and some of the other guys who have tons of videos online to learn. And then you attend some of the conferences.
Right.
What pushed Dr. Amy over the edge was I had given her information material, said, hey, learn about direct primary care. She ended up going to a conference, a local conference. It was a one-day conference, and took her husband with her because that was some of the drawback. Was his concern was, hey, you're getting a regular paycheck now. Why are you trying to go out and go on your own?
Right.
And so when they went to that conference together, they came back home and they were like, hey, we're dumb. We're stupid if we don't do this.
I'm glad he saw the light.
And so she really wanted to do it, and she got a lot of contacts from the DPC community, which, as you may know, is quite a together family-oriented group to try to help people. There's a lot of resources out there. There's the DPC Alliance, which I'm one of the founding members of, which is really trying to help people find their way, find contacts, find resources, And so that there's a lot of that going on, but we got a lot of stuff off the internet and going to conferences and found mentors and
Right.
basically and just did it.
Yeah, and I've found that the beautiful thing through, my presence on social media, how I came in contact with you, in fact, I found that the beautiful thing about this DPC, the direct, all you guys call it direct primary care. I prefer direct patient care. Who knows? 6 one, half dozen the other. Who cares? But the DPC movement, what I found is how hospitable, how inclusive, how absolutely willing everybody is to share their success stories and to share how they're doing things simply because they want this model to work. DPC doctors realize, unlike corporations that want to take over the world or take over the universe, us DPC docs realize that we have a limited set of patients that we're going to see. That means a limited revenue stream, a limited income potential. So we're not jealous. We're not interested in taking over, I will never practice in South Carolina and be a threat to you. So why don't I share my success with you? Why don't I share my failures with you? And let's help each other out to establish the best practice, not only for ourselves, but for the patients as well. So that's really interesting. So you learned a lot from online, the community, etc. So tell us how actually implementing this goes. And let me preface my question by saying there's 2 ways to do this, really. You can go at this like I did as an emergency physician where you have no patients. I had nobody. I mean, there was nobody. I had to literally put a sign up, put it out there, market it, etc., try and get patients through the door, trying to get them to understand the value of paying a complete stranger when they believe in their health insurance. And then there's the model that it sounds like Amy did, your partner. I'm sorry, what was her last name, Dr.?
Cianciolo.
Dr. Cianciolo did, where she moved from the established practice, although she may have had a non-compete. There may have been some difficulties there. I'm sure there were. But then it sounds like you did the hybrid model. You had you had an urgent care practice where you're seeing patients, probably not that repetitively for their urgent care needs, maybe a few of them. So tell us how that went for you. How did it go from 2015 onwards as far as building up your actual number of patients? And tell us how many patients y'all decided on as part of your panel. Because one thing about DPC is we have to have a limited number of patients so that we can provide them with excellent, 24/7 call coverage and instant responses. So we have to necessarily limit our patient panel size. So tell us how you decided that, what your panel size is, and how it's been going.
Yeah, well, when we came together, she did have her own. She had around 1,300, 1,400 patients in her panel where she was working at in the fee-for-service world. And she was able to get some information to them. And she was able to get pretty quickly, within 6 or 8 months, 300 or 400 patients to come with her. And so, which was a good size. She wanted to sort of restrict her panel to 450 to 500 because her husband's in the military and he travels a lot. And so has kids at home, and so she was doing a lot of mom stuff.
Right.
And so she knew that she was going to sort of work less hours in the office, but spend more time over the phone and doing stuff. So she wanted less of a panel size. I was more of a traditional, I'm looking around the 600, but depending on, how stable they are, how I could push that up to 700, depending on, how the patients are.
Right.
And so when I started, I'd still had a small following from my cash clinic that were seeing me through the urgent care.
Okay.
And I was able to get, maybe 50 or 75 of those people to come with me to join. And I actually initially ran my DPC clinic. We were at separate locations temporarily. She had her office, and I had my office inside the direct primary care. So we were the same office, same tax ID number, just in separate locations temporarily. Okay. And so that allowed me to manage my urgent care, which was still a cash urgent care at the time. We had dropped out of insurance in around 2015, which allowed me to do the DPC. And then the urgent care became a huge drawing factor for people to sign up for the DPC because we were constantly seeing people with sinus infections and their blood pressure is bad. Well, you need regular care. We'd find people come in for DOT exams and we'd diagnose them with diabetes right on the DOT exam. So they need a doctor. They don't have insurance.
Wow. Yeah.
So we would pick up 10 or 20 people a month coming through the urgent care.
Right,
And so
right.
it took me about 3 years to get to about 300 patients. So it's a slow grind, slow grind. Dr. Amy got nearly full pretty fast because a lot of her people, and there's this phenomenon in DPC called the snowball effect that really does happen. It's some magic number you get to. It seems like the patients just start rolling in,
Right.
and different practices is different number. Some people it's around 200, 250, and then the word of mouth just begins to
Right.
explode.
Right. The word of
And
mouth. Yes. Yeah, that's been my biggest factor. I've tried marketing. I have a funny story. It's not so funny. It's actually sad, tragic. I sent out one time for my clinic. This is back in 2014, and I live in a I live in an urban area. Well, I'm suburban, but in the Dallas-Fort Worth area, there's 5-6 million people around here to choose from. So I picked the local major newspaper, the Fort Worth Star-Telegram. They offered me this advertising gig. I paid them $1,500 a month for 3 months going straight. And they put in one of their circulars a little insert sideways, and it had, this is back when I was doing my urgent care days, it had 15 minutes where it's free. I made that promise to patients. If you have a scheduled appointment and you came in for 15 minutes, hey, if I didn't see you within 15 minutes, the visit was on me. Otherwise, it was $99. And so I put this out there, and it went out to 12,500 households. Now, conservatively, that's 37,500 people, probably closer to 50,000 people, 3 months in a row. Now, my understanding is the general rule of marketing is that you get a 1% response rate, either a callback. That's not conversions. That's not that 1% of the people are going to buy whatever you're selling, but a 1% response rate, which would equal, if it was 37,500 households, you would expect 375 people to call or what have you. Guess how many people called over the next 6 months? 9. 9 people called. Now, again, this is back in 2014 timeframe, so this is quite a while ago. This is, most people, a lot of people since then have become more aware of what their health insurance is doing, that they have to pay for their health care anyway. But I was really, it was a low blow to my esteem, I got to tell you, because I couldn't make it work. In fact, I had to close my clinic down last year and just go to a house calls based model because I couldn't afford the overhead here in the Dallas-Fort Worth area. But I was trying marketing at every turn. I had a radio show on Sundays here in the Dallas-Fort Worth area. That lasted for 3 months. I had to pay an outrageous amount to have a 30-minute radio show. These podcasts cost me nothing. Thank you so much for coming on, Shane. But basically, I was paying lots of money and not getting any response either. So I guess my point about this entire rant is that marketing will only get you so far. Really, it's the word of mouth. Really, it is getting those patients, treating those patients like they're a part of your family. As the DPC model says, treat them like they're your family or your friends. Just be on call for them. Provide them with excellent customer service, affordable prices, and just reasonable expectations. I mean, I'm telling you right now, once you reach that magic number, that critical mass, I can see it taking off. Unfortunately, my clinic, my brick and mortar clinic, just never got there. It's happening with my house calls practice, but I've had to morph my practice to meet how things are going here in the Dallas-Fort Worth area.
Mm-hmm.
So again, I'm sorry for going off on that rant in the mid topic there, but tell us how things are going now. I understand that the slow grind for your practice has now disappeared officially.
Yeah.
So tell us about some recent events.
Yeah. So when we first started, one of the main things that we tried to do was reach out to small businesses that really weren't providing any insurance, and we sort of were able to catch the ear of some of the community leaders, which was interesting. And actually, one of Dr. Amy's patients works for the county administrator here in our county, and
that's helpful.
That's always helpful.
Yeah,
that's how you end up picking up a lot of businesses, because when the owner of the business comes here and they're like, "Man, this is really great. I think I should sign up my whole staff."
Mm-hmm.
And so you get a small company of 20 people sign up.
Right.
So we also were blessed to be able to have one of the county council members live in my neighborhood. And she was super conservative and was really concerned about how much money the county was spending for healthcare.
Sure.
And we're looking for other avenues. And so we were able to meet with them really 3 years ago, was how long it took to sort of get this ball rolling. We met with her, we met with some of the county council people, and at the time they were locked into a a Blue Cross Blue Shield type of plan for their employees for the county, and so there was nothing they could do. But they had the seed was planted, and they were like, okay, we understand. We actually brought in from out of town an HR person from another county who had used the direct primary care model and saved them tons of money. He came in and presented to the county council to show them what's possible.
Wow.
This was like 2 years ago. And so last year, they read the tea leaves and could see the writing on the wall. This was not going to be sustainable.
Yeah, they probably got another double-digit increase on their health insurance premiums from all the flu shots and doctor visits and things like that being covered by health insurance. Yeah.
And so they were looking for a way to change that. And so they started traveling around looking at other areas, what other companies and organizations were doing. And they brought us back in. We talked to them some more. We were able to get them connected with some of the brokers, advisors that really understand how direct primary care works, because that is critical if you're going to work with those folks. And they decided to go gung-ho and basically dropped traditional insurance and went to a third-party administrator and fully 100% self-funded with a DPC option for their employees.
Wow.
Wow. We were happy, we were excited, we thought it would be really good for the community, really good for our business as well.
Yeah.
And then what happened was we thought, well, okay, they're going to allow, they offer two options, a standard plan and the direct primary care plan. The overhead insurance was the same for everyone. So if you needed surgery, you were getting taken care of no matter what.
Sure.
It was only the primary care part that was a little bit different. And so it didn't cost the employee any difference. So you can choose DPC or the standard option plan. But anything you did in our clinic basically was covered. So any medicines we had, any labs we had, they didn't pay anything for it. So it was
the employees, you mean? Yeah.
Yes.
Yeah.
It was a really good plan for them to save a lot of money.
Now, just to clarify, you're talking about an entire county. You're talking about the county that you live in, the county's employees. And how many folks are employed by the county there approximately?
Almost 1,000 employees.
Wow. Okay. So that's a big chunk of people. That's a lot of money the county was spending. You bet.
A lot of money. So, and we were conservative. We said, well, we figured, nobody really understands what we do. We had several big meetings with all the employees where they actually let us, all four physicians, stand up and speak and tell them what we did, which is helpful.
Yeah.
And then we figured, conservatively, we'll probably get maybe 300 or 400. We think a lot of people will sign up, but maybe 300, 400, which will be great and incredible. Well, what happened was 2/3 of the people signed up, and we had over 700 new patients. Basically overnight.
Wow. So,
starting January 2nd, basically when we opened back up, we almost doubled our whole pool of patients, and which is a whole nother long video about how do you get all those people in.
Right. Don't worry, we'll do one.
But now we have 4 providers, and 3 of the 4 are 100% full. And the 4th one probably by July, because we're having other people call in. It's that snowball effect, when it gets out that, hey, the county's doing this, then everybody wants a piece of that action.
Yeah, sure.
Our fourth provider will be full probably by June, by the summer.
Well, sounds like y'all ought to start recruiting some family medicine residencies, bring in some other folks, it sounds like.
Yeah, that's coming.
That's incredible. Congratulations. I mean, really, that is a success story and a half for your business as well as for your patients and for the county. Think of how much money. I know you don't have the facts and figures yet, but I presume in the next year or coming years, you're going to have some astounding facts and figures about how much the county is going to actually save by doing what it did. That's a whole nother topic, a whole nother podcast, and I do a whole nother series called Healthcareonomics for Employers, where I'm talking with brokers, benefits brokers, employee benefits specialists who have decided to kick the traditional health insurance model to the curb and do it the way you're saying, by becoming DPC experts, by trying to find their clients, the employers, the biggest discounts and the biggest deals they can. And I want to kind of close with this thought too, that you've just illustrated for the audience exactly the problem that faces primary care or direct patient care, DPC, whatever you want to label it as. The problem is the patient load. The problem is you can establish a practice, you can call yourself whatever you want to, you can market, you can put ads in newspapers, you can go door to door, whatever you want to do. But really, until you convince the patients that what you're doing is valuable to them, and it's valuable to them to pay you money to do what you're doing for them, which it is. I mean, they just don't understand. I like to say, if you have a $3,000 or $5,000 deductible on your health insurance, congratulations, you're a healthcare consumer. Now act like it. But not enough patients are getting that message across. So I think why I wanted to have you on the show today really was to discuss your success story by going to employers. And employers are the keys, because they're the ones who are paying for a lot of this mess. They're the ones getting stuck with the bill. They're the ones getting ripped off the most for this mess. So going to employers as a DPC doctor beats putting an ad in a newspaper any day, at least at this point in time. In the future, that may change, but for now, going to employers is the key. So, Shane, I absolutely am just thrilled for y'all's success, really. I mean, I wish y'all the best. So tell us, do y'all have any plans for expansion, or how are y'all going to handle this upcoming onslaught?
Well, we've thought about that, and so we have managed to get, basically, we did it the best way we could do with the new employees coming in. We went ahead and scheduled as many people as we could, and we have new patients coming in through the middle of April, and then we will have seen pretty much all our new patients by then. Wow. And so anybody who's been sick with the flu, colds, that kind of stuff, in the middle, we bring them in and see them anyway.
Sure.
And so we just so within the next 3 weeks, we will have everybody seen.
Wow.
At least one time for their initial visit, and got to feel, what do you need, what's going on in your world. And so the future is, we have room for probably one more physician where we're at. And so looking at, do we need to go ahead and consider adding that extra person sometime by the end of the year?
That's awesome. That's fantastic. So tell us, how's your life been since switching over? You never really did the. It sounds like you've been like me. You've been the entrepreneurial type your entire career. But tell us, how's life going? How do you see the rest of your career panning out? You got hopefully another 25, 30 years of doing this. So I bet you're excited about it.
Well, it's certainly way different. The advantage, one of the advantages from a DPC point of view is that's different than the cash world, is you do have that monthly revenue coming in,
sure,
which is somewhat guaranteed. I mean, there are some people, when you're dealing with employers, that's a little more guaranteed.
Yeah.
The individuals, sometimes you have to track down.
Right.
But it's doing urgent care, as you probably well know.
Yeah.
You could have 5 people show up, you could have 50 people show up, and you're basically at the whim and mercy of people. And so from a financial standpoint, it puts you in a lot safer place.
Yeah.
From your family, and being able to pay bills. And this year will be probably, I've been doing it for 17 years now, I guess, and this will probably be one of the best financially stable years I'll have.
Great.
Because when you're on your own business, you're the last one to get paid.
Hey, that's right. That is absolutely right.
Some years you don't bring home as much as others.
You bet. Absolutely. Well, listen, again, I want to thank you so much for coming on the show. Why don't you give us the links to your practice, because I'm going to include them below, but give us how we can get in touch with you, anyone who needs to or wants to.
So our website is directaccess.md.
Okay.
So www.directaccess.md.
Okay.
And then you can get my emails and stuff are right on that website if you wanted to get there. But there's several ways to get in touch with us right off of our website.
And then you can also follow Dr. Purcell on Twitter, and you're on LinkedIn, correct? I believe you're on LinkedIn as well.
I am on LinkedIn and Twitter. Yeah. I think my Twitter is Doc Shane P. I think that's it.
Okay. I'll definitely have the links below, so anyone who wants to can follow you. Again, Dr. Purcell, thank you so much for your time. I appreciate it. Until next time, everybody, stay healthy. Now you can easily compare health insurance plans and pick the one that makes the most financial sense with the Dr. W's Equation app, available for Android and iPhone. And for more information on how you can save on health insurance and healthcare, check out my books, available now on Amazon, iTunes, and Nook. To help spread this message, please click the like button on this video. You can also subscribe to the Healthcareonomics YouTube channel and visit healthcareonomics.com.